Record.
Okay, Nirusha.
Okay, ma'am. Should I start, ma'am? Should I wait for others to chat?
9 అవ్వలేదు కదా ఇంకా
Available.
9:05 దాకా వెయిట్ చేద్దాం. నిరుష విల్ వెయిట్ till 9:05.
Okay, ma'am.
below for hospital hypertension. So Dr. Nirusha will be presenting on development of the skin and bridging the gaps in preterm skin care. As we all know that skin is the largest organ, and during the various procedures and during the care of the babies in the NICU, we breach the skin during various procedures, and in turn which leads to various infections in the baby. So it is the duty of us, all of us, to protect the preterm skin care in order to avoid the morbidity and mortality for the preterm baby. So Dr. Nirusha will be covering on this.
Good evening, one and all. Thank you, ma'am. Today we'll be dealing with the development of skin and bridging the gaps in preterm skincare. So, just a second. Okay. So the contents of the talk will be like we'll be talking about brief introduction, then functions of the skin. We'll be talking briefly about structure and development of skin, vernix, acid mantle, and microbiome. Then how we'll be dealing how is a preterm skin different from the term baby, and the role of humidification on barrier maturation. Then neonatal skin assessment. Then all the iatrogenic injuries in the NICU, how to prevent it and how to treat it, and then general skin measures. Then we'll be dealing with summary. So introduction, skin is the largest organ in the human body. It has many vital functions like barrier integrity and immunological functions and so on. The skin of a newborn is different from adult skin, and this calls for a special care. However, it is not given due attention as we give to other organs like lung and heart and everything. So there is an urgent need for formulation of standard recommendations for skin care of newborn based on the available literature. So functions of the skin, mainly it is a barrier function, physical barrier. It is a barrier for UV exposure or light, and immunological barrier, resilient to mechanical trauma. It is a first to come in contact with the caregiver. So it has a function of sensation, tactile discrimination, light touch, thermal regulation, and acid mantle formation. So we'll be discussing in briefly about each of these functions. First, we'll discuss about the structure so that we'll be better aware of the functions. The structural biology of fetal and neonatal skin. So all the time we'll be dealing with epidermis and dermis, but there are other things that are very important like skin microbiome, which forms a biological barrier. This is a biological barrier, skin microbiome. Acid mantle, which forms a chemical barrier. And among the epidermis, all the layers of epidermis, the outermost layer, the stratum corneum, has a lipid bilayer that is a physical barrier. So apart from all what the things we deal all the time like epidermis and dermis, these three are also important, and we'll be discussing about these three in detail. And coming to the epidermis, there are 4 layers of epidermis: stratum corneum, stratum granulosum, stratum spinosum, and basal layer. Of all the layers, stratum corneum is the most important layer, and dermis has 2 layers again. And the thing that binds the dermis and the epidermis is a basement membrane, which has anchoring filaments that helps in binding epidermis to the dermis. So coming to the epidermis, as we have discussed, there are 4 layers, and stratum corneum is the most important layer. It has lipid bilayers between all the corneal sides, and they are bound by desmosomes. Stratum corneum is of 16 layers. So this is a structural and functional division of the epidermis. Whereas coming to the cellular composition, keratinocytes form the 80% of the composition of epidermis, whereas non-keratinocytes in the epidermis are melanocytes, Langerhans cells, and Merkel cells. These are primarily immigrant cells. They come to the epidermis. They are not innate cells of the epidermis. And melanocytes, they are primarily important for melanogenesis. As we all know, it's a continuous process. So as the skin shreds, new melanocytes are formed and new melanogenesis occurs. So, and also the skin is not fully pigmented at birth. It darkens over the first few months. Merkel cells, they appear at 8 weeks of gestation. They serve the mechanoreceptor function like the light touch. And Langerhans cells first appear at 40 days of gestation. They are the antigen presenting cells of the skin. They increase significantly during the third trimester. So they primarily function for the immunological activity or function of the skin. And because they are significantly increased in the third trimester, preterms usually lack Langerhans cell functions. And development of epidermis. I will not discuss everything in detail, but the most important thing here to notice, as a progression of epidermis, you can see here all the layers of epidermis are formed. In the late fetal period only, the epidermis is fully formed. Like in the embryonic period, it is only of 2 layers. So any preterm that is born before the gestation, it is a continuous process till term gestation. So any preterm is deficient in the layers of epidermis, especially stratum corneum. And the outermost layer here in the embryonic period is a periderm, which is a transient layer that covers the embryo and the fetus until the epidermis keratinizes in the second trimester. So if you want to summarize the stratum corneum functions, it is the epidermal permeability barrier. It has 16 layers in full-term babies. It's only 1 or 2 layers thick in preterms, and Elgans or ELBWs completely lack stratum corneum, and it reaches functional maturity by 33 weeks of gestation. Because they lack stratum corneum, or it's only 1 or 2 layers thick in preterms and Elgans, they are more prone to transepidermal water loss. So here we can see electronic microscopic image of stratum corneum in preterms versus term. As we can see, the stratum corneum is not very mature in the preterms, and it leads to increased transepidermal water loss when compared to the terms. So each ml of water that is lost by evaporation expends 0.58 kilocalories, which is a significant loss for preterms, and it could lead to a lot of morbidity, which we usually forget to calculate. So, and this difference between the cutaneous permeability in the preterms and terms, both preterms and the terms, decreases with each postnatal age. And the epidermal barrier of the VLBWs, when compared to the same corrected gestation age of the terms, it is still lacking in the barrier function. So it is important. Next, coming to the Vernix caseosa. Vernix is a unique material that coats the fetal skin during the last trimester of the pregnancy. So it contains lipids of sebaceous origin, and it is a hydrophobic material. The primary function of Vernix is because the fetus is in the amniotic fluid, it is in the aquatic milieu. It doesn't. If the Vernix is not there, it doesn't develop. If what happens if we immerse our hands in water for some time, all the washer and hands and epidermis is stripped off and everything happens. But this is prevented by the Vernix, and it coats the fetal skin. It is a hydrophobic material, and it helps in waterproofing the skin surface, thereby allowing cornification to occur. So synthesis of Vernix is thought to begin around 28 weeks of gestation. So any preterm that is born before 28 weeks of gestation that lacks Vernix. The major components of Vernix, though it feels very greasy to touch, lipids are only 10% of the Vernix, and water is 80% of the Vernix. Among the lipids of the Vernix, as you can see here, ceramides form an important component of the lipids. This is important because ceramides are the primary emollient function of Vernix. Sorry. There is a proposed mechanism for surfactant mediated Vernix detachment. That is in the late trimester, when the lung matures and produces surfactant. Amniotic fluid becomes cloudy because of detached Vernix, and fetus swallows this amniotic fluid that has Vernix. And essentially, this is the first feed that the fetus takes, which contains nutrients and primes the gut for extrauterine feeding. This has a Vernix has a close analogy to breast milk. It has multiple molecules that are associated with innate immune system, like lysozyme, lactoferrin, defensins, and antioxidants also. So all the biological functions of Vernix, it is a waterproofing layer as we discussed. It has anti-infective barrier. It has lysosomes, lactoferrin, defensins. It has antioxidant property. It has alpha tocopherol, which is vitamin E. It has moisturizing property because it has natural moisturizing factors, that is filaggrin. It prevents drying and desquamation. It has cleanser function, wound healing agent, and it also absorbs environmental toxins. Because of these properties support Vernix detention at birth and align with the WHO recommendation on delayed bathing. Next, next layer, which is of importance, is acid mantle. The acidic skin mantle is necessary for the formation of an effective skin barrier. The pH is around 4 to 6. The acidic pH is essential for bacterial homeostasis, skin colonization with commensals, and inhibition of pathogenic bacteria like staph. So full-term infants achieve acid skin surface by 4 to 8 weeks after birth. At birth, it is slightly alkaline, and they develop the acid mantle, and the acidic pH develops by around 48 weeks in the term babies, whereas in ELBWs, it requires much more longer time. Why is it important to know about acid mantle is, whatever cleansers or emollients we suggest, they should be in the range of this acid mantle. Otherwise, we might give a risk of damaging the acid mantle and increasing bacterial colonization. Next is the skin microbiome. Initial colonization of the skin is dependent on the mode of delivery. So infants born via C-section, they predominantly have maternal skin commensals, whereas infants born via vaginally, they are dominated by lactobacillus species. And development of appropriate microbiota is necessary for optimal innate immune system. Innate immune function. So exposure to chorioamnionitis, perinatal antibiotics, probiotics, and environmental factors likely influence the diversity of developing microbiome. Premature skin has lower bacterial diversity than full term, and maternal and full term infant, the skin microbiomes of the maternal and full term infants are similar by 6 weeks of postnatal age. So after dealing with all the layers briefly, then how is preterm different? So as we have studied, preterm corneum is only 1 or 2 layers thick, so it leads to more transepidermal water loss, and melanosomes are only 1/3 of the term. They are more prone to photosensitivity. Langerhans sensile spars, so they are less immunogenic, and connections at the dermal epidermal junction is weak. That is the anchoring filaments which I have shown at the basement membrane. They are weak, and that's why when you put any adhesive on the preterm skin and when you remove adhesive, the bond between the adhesive and the epidermis is stronger than the epidermis and dermis. So there is a likelihood of epidermal stripping and dermal layer exposing with the adhesive removal. So that is one more risk. And dermal elastic fibers as parts, it leads to less elasticity and more blistering. And preterms have scanty subcutaneous tissue and non-functional sweat glands. Because of this, thermoregulation is difficult, and microbiome and acid mantle are incomplete. It leads to more infections. This is a table comparing the values in preterm and term. Most important is transepidermal water loss, which is very high at 26 weeks, and it becomes low as the neonate matures. And then next, the role of humidification. To know what is the role of humidification on skin maturation, first we'll talk about transepidermal water loss and etc. So this picture is depicting transepidermal water loss is 50% relative humidity. So transepidermal water loss is inversely proportional to the gestation age. As the less the gestation age, more the transepidermal water loss. So here the boxes represent transepidermal water loss of a 22 to 23 weeks neonate, and the dotted lines represent 24 to 25 weeks neonate. And apart from this, and there is a rapid postnatal maturation of skin, resulting in almost 50% drop of transepidermal water loss by postnatal age of 1 week. So this is on day 1 and 2, and this is by 1 week. You can see the transepidermal water loss has decreased by 50% in the first 1 week. So this is another table representing the transepidermal water loss in radiant warmer versus closed humidifier. This is a line that represents a epidermal water loss in radiant warmer with plastic wrap, that is 50% relative humidity, and this is a closed closed incubator with a relative humidity of 80%. The same destination is neonate. On day 1 in a radiant warmer has 200 ml per kg of water loss, whereas in closed incubator, baby has 80 ml per kg of water loss. So it decreases as the gestation age increases. And this evaporation is the water is in the skin is inversely proportional to the absolute humidity of the surface. So placing the ELBW in a closed humidifier helps with the fluid and electrolyte balance better. When the infant is placed in a radiant warmer, it becomes very difficult to manage the fluid and electrolyte with this amount of water loss. So this is one advantage of putting the baby in a closed incubator. But what happens is placement of a ELBW in a high humidity environment like a closed humidifier, 80% relative humidity, causes the skin surface to be very wet, and it delays the skin barrier maturation or cornification and creates condition for bacterial growth, mainly Pseudomonas. So ultimately, we can we can balance better between fluid and electrolytes, but we are delaying skin maturation when the baby is in a incubator. So a decrease in relative humidity from 80 to 85% down to 50% is necessary for skin maturation or cornification. So there is a study where fluid management for considerations in extremely preterm age was published. There, the study states that infants born at 23 to 25 weeks of gestation who are maintained at 85% relative humidity for 7 days, followed by either relative humidity of 50% for 4 weeks, demonstrated improved skin barrier integrity. So this is one study, and as we have discussed, radiant warmer with plastic wrap, it provides 50% relative humidity. So comparing humidified incubator versus radiant warmer with plastic wrap, humidified incubator has significantly less transepidermal water loss, but the drawbacks with incubator is poor visibility, limited access, growth of bacteria, and delayed skin maturation. Whereas in radiant warmer, it significantly increases transepidermal water loss, so it becomes difficult to manage fluid and electrolyte balance, whereas low ambient humidity results in more rapid barrier maturation. So how to balance between this fluid loss versus barrier maturation is, it is reasonable to use incubator with high humidity for the first 1 week and then rapidly drop the humidity to 50% after 7 days. Then coming to neonatal skin assessment. So neonatal skin condition score is used to assess neonatal skin. It has 3 components: dryness, erythema, and breakdown. Each one has 3 scores again. So the total scores comes to 9. So dryness, 1 is normal, no signs of dry skin. 2 is dry skin, and 3 is very dry skin with visible cracking and fissures. Erythema, in 1 there is no evidence of erythema. 2 is visible erythema, less than 50% of body surface. 3 is visible erythema, more than or equal to 50% of the body surface. Breakdown, 1 is non-evident. 2 is breakdown limited to small localized areas. 3 is extensive breakdown. So perfect score is 3 and worst score is 9. For instance, if we take this neonatal skin condition score comes to 9. Dryness is very dry, visible crack, score 3. Erythema is extensive, more than 50%, score 3, and breakdown is extensive, score is 3. So importance of this score is, a neonatal skin condition score is to be documented within the first 4 hours of admission, and this has to be documented for each nursing shift thereafter. The score is to be documented on the infant's observation chart, and any score more than 3, when the nurse tells that the score is crossing 3, an action plan has to be documented in the patient's prognosis notes. So all the iatrogenic injuries and skin related injuries, what is the treatment plan, I'll discuss later. This is how you have to score for neonatal skin condition score. So coming to iatrogenic injuries and prevention and treatment. Iatrogenic injuries are of various types: mechanical injuries, medical adhesive related skin injury, pressure ischemic injury, chemical injuries, extravasation injury, and diaper dermatitis. So it is a pictorial representation. As you can see here, prematurity has only few stratum corneal layers, whereas occlusion with any waterproof dressing or any occlusion causes disruption of lipid layers and occluded stratum corneum. It also causes skin damage. Then any irritants that are on skin and we forget to wipe it off, then it causes lipid disruption, cells damage, irritants penetrate and microbes have access. And tapes when they are removed, like adhesives when they are removed, layers of the epidermis are stripped off. So coming to each one of them, mechanical injuries, this can be caused by the monitoring devices used during labor, or lacerations can occur in emergency cesarean section also, especially those with oligo, and forceps delivery also we can see damage on the cheeks. So how do we treat these injuries is the wound should be covered with deodorant. So mechanism of action is this keeps the wound bed moist and reduces pain by preventing the nerve endings from drying out and promotes rapid healing. And for these injuries, baby need not be admitted to the hospital. Parents can be taught how to dress it till it heals, and they can be discharged. And they can come on outpatient consultation. Next is MARSI, which is medical adhesive related skin injury. For a preterm neonates, as we have discussed, epidermal stripping is a serious consequence of adhesives because the bond between epidermis and adhesive is stronger than the bond between epidermis and dermis. So when the product is removed, epidermis is stripped off, leaving the dermal layer exposed. So how to prevent MARSI? So how to before knowing about prevention of MARSI, we have to have some basic knowledge of adhesives we use regularly in the NICU. So briefly about adhesives. First is a silicone adhesive, and the brand name is Mepilexlite or some other brand. But the silicone adhesives are the only atraumatic adhesives in the market, and they are best by far. They can be removed easily and painlessly. They can be removed painlessly even in the hairy areas. That's why they can even be used for EEG monitor attachment, and they don't alter skin barrier function. But the only disadvantage with the silicone adhesives is they have weak adherence and it becomes difficult to use for life-saving devices like ET tubes and all. So, and that is with the silicone adhesives. Next is the hydrogel adhesives. These are less traumatic, they are breathable, but they have less adherence like silicone devices, silicone adhesives. But they are more useful when when we use it for wound dressing, because they have a property of absorbing the exudate. So they can be used for severe epidermal injury dressings. Next is a hydrocolloid adhesive. Example is deodorant. It can be used as a platform under adhesive tapes. It is water vapor permeable. It is gentle on removal like silicone adhesive, and it also facilitates skin barrier function when left in place. Next is polyurethane adhesive, that is Tegadum. It is a transparent dressing. It is critical where visualization is important, like for IV cannulas and UVCs. It is semi-permeable and it is more painful and removal than hydrocolloid, that is Deodum. This is a picture representing silicone tape used for EEG electrodes. And the other products which are very new are skin barrier products. Apart from skin friendly dressings, these are also being used now. They provide a protective coating between the epidermis and the adhesives, where in the IV cannula, when you have to put a Degadum or any other dressing, where you can't prevent adhesive injury, you can spray this Cavilon, or this can reduce the risk of MARSI. They are available as liquid wipes or sprays. After application, the liquid part of the barrier evaporates and leaves a transparent breathable protective coating. Of these skin barrier products, alcohol free products are recommended to decrease excoriation. Cavilon is one example, which is a no stinge, non-alcoholic barrier film. So general preventive measures for ELBWs from MARSI is when you identify moist areas of immature skin, use a water vapor permeable dressing like silicone adhesives and replace the dressing every 8 to 12 hours to avoid wet dressing against the skin. And identify skin wetness in folds like in axilla, neck and popliteal fossa, and also dress them with absorbent foam dressing like Mepilexlite, that is silicone dressing. Face protection, apply thin semi-permeable dressing such as extra thin dressing deodorant to the cheeks to protect the skin from adhesives, as you can see in the picture. So how to attach a temperature probe to, as a reflective material that reflective hard semi hard that is used on the temperature probe, it causes adhesive injury. To protect it from the adhesive injury, first we have to take a silicone tape or any other product which is skin friendly, and we have to cut that in a shape of in a small shape that to fit the temperature probe, and put the adhesive, and then put the temperature probe. Above that, put the reflective dressing, so that the reflective dressing doesn't touch the skin. So when you remove it, below it is a silicone tape or any skin protective dressing. So how to fix the umbilical catheter placement? As we see all the time, ELBWs are very preterm babies. When we fix the umbilical catheter and when we remove it, we see a lot of adhesive related injury. So this is one way which we can how we can prevent the adhesive related injury. After the lines are secured to the cord, secure lines where those lines are to be secured by the remaining suture around the catheter, and then create a box around the catheter with a clear tape to visualize the markings, and to that add cloth tape to the periphery to minimize abrasions. Avoid fixing the lines to the periumbilical skin. This way we can avoid adhesive injury. We need not attach the UVC to the skin at all. And next is IV cannula. As we have discussed, the occurrence of epidermal stippling injuries has been reduced with the application of non-alcoholic barrier film under the film used to secure IV cannula. Next is the pressure injuries due to medical devices. Example, CPAP mask, electrodes, pulse oxy probes, temperature probes, and endotracheal tubes. And pressure injuries can also occur on the occiput of the head if the baby is nursed supine for a long periods. And in the example during ventilation, hands and feet can also suffer ischemic injuries from the saturation probes. And central catheters, peripheral IV hubs can also cause injuries. So this is one example of pressure injury from a temperature probe. It has healed with the application of diodum. So skin assessment score for pressure area specific to CPAP, high flow and ventilated infants. Score 0 is intact non-compromised skin. Score 1 is stage 1 is non-blanching erythema. Stage 2 is superficial erosion. Stage 3 is necrosis of the full thickness of skin. So how to prevent this pressure related injuries is periodically check the skin under the devices. Rotate devices every 8 to 12 hours to minimize effects of pressure. And for CPAP, apply a small piece of absorbent foam dressing to the nose bridge under the mask. For nasal prongs, cut 2 holes of piece of diodum and place it in between the nose and the prongs. The other thing is this can also be used. It is called a cannulate. It is called a cannulate. It can also be used to protect from nasal prongs injury. And other thing is consider rotating CPAP masks of various size, or alternatively rotate it with mask with nasal prongs. For some time you can use mask, and for some time you can use nasal prongs to reduce pressure injuries. And at every assessment, evaluate the nose bridge, nose tip, and upper lip, nostril, and nasal septum to look for any erythema, skin breakdown, and tissue loss. Next is chemical injuries. So chlorhexidine, we use a variety of skin disinfectants in the NICU. Of that, we have 3 options primarily: chlorhexidine gluconate based, povidone iodine, that is betadine, and alcohol based. Chlorhexidine is by far the best anti disinfectant in the NICU. It is of various percentages, 0.2 and 0.5 and etc. But it is broad spectrum and has a longer duration of action. Povidone iodine is potential to get absorbed and cause hypothyroidism, and alcohol is also broad spectrum. But in 2014, drug safety update was published by UK, which says that severe skin adverse events has been reported in extremely preterm infants who were treated with chlorhexidine gluconate, both in aqueous form and alcohol-based solutions. So the recommendation is recommend more than 28 weeks and more than 1,000 grams you can use chlorhexidine, but in less than 28 weeks you have to be careful with you are using chlorhexidine. It is preferably avoided, and skin disinfection can be done with povidone iodine and isopropyl alcohol. Once we have studied all the injuries, how to treat these injuries. Management of epidermal injuries from MARSI, pressure injuries, and chemical injuries. Before proceeding to treatment, we have to analyze the depth of the injury, whether it is fitting into mild, moderate, or severe. So mild is only loss of superficial subcutaneous stratum corneum. Moderate is loss of stratum corneum and the epidermis. Severe is loss of complete epidermis and the dermis. So how to treat it? So mild, in the mild case, we have to clean it first with warm NS or sterile water. Then that NS or sterile water has to be blotted dry. You should never rub it vigorously. And then cover with absorbent foam dressing like silicone dressing, as we have discussed, like Maplex Light. And inspect every 24 hours and change if soiled. Why we are insisting on dressing the wound rather than leaving it to air is there are two types of wound healing basically. Wet, moist wound healing and dry wound healing. In neonates, moist wound healing is said to be superior than dry wound healing. So the studies have suggested to cover it with any absorbent foam dressing like Maplex Light. If there is no exudate, you can cover it with Maplex Light and inspect at 24 hours and change if soiled. What to do if there is an exudate? Coming to severe, moderate is same as mild if worsens treat as severe. Whereas in severe, clean and dry like mild. When exudate is present, we have seen the different types of dressings where there's a hydrogel dressing. So if the exudate is present, you have to cover the wound with hydrogel, then cover it with silicone dressing like Maplex Light. So the hydrogel absorbs the exudate, and once the exudate once you find there is no exudate, once the wound has healed and epithelialization occur, granulation tissue has formed, when there is no exudate, you can remove the hydrogel and apply a new dressing with Maplex Light. Coming to extravasation injuries, there are four stages of extravasation injury. Stage 1 is only the IV cannula flushes with difficulty and there can be pain at the site, but there's no sign of injury. Stage 2 is minimal swelling with redness and pain. Pulses are normal. Stage 3 is moderate swelling and pain and blanching with cool skin. Pulses and perfusion are still normal distal to the access site. Whereas stage 4 is severe swelling and decreased or absent pulses and perfusion distal to the access site. So the tissue damage also depends on the extravasate volume, concentration, and physicochemical properties. So AAP recommends solutions with osmolarity less than 900 milliosmoles for peripheral administration, whereas Infusion Nurses Society recommends only less than 500 milliosmoles solution for peripheral administration. Vasoactive medications also pose increased risk. So how to manage this extravasation injuries? Non-surgical management can be done for mild to moderate extravasation injuries, whereas surgical management is advised for severe extravasation injuries. Otherwise, they would end in amputation or permanent disability. So non-surgical management will be like pain relief, limb elevation, cold compressions, and sometimes for some other drugs of types of extravasation, heat compressions and dressings. For surgical management, saline irrigation and with or without hyaluronidase injections and definitive surgical interventions are two options. So this is a Cochrane database of systematic review where they have published saline irrigation for management of skin extravasation injuries in neonate. They have published that saline irrigation is associated with better outcomes in management of extravasation injuries, but the quality of evidence is very low, and there are no RCTs based on this. So they have studied only case reports and case series. Further RCTs are needed to confirm these studies. So this is one case series of neonatal extravasation injury. They have managed with both these cases with saline irrigation and flush out technique. So you can see the before and after images. So this is how saline irrigation illustration of hyaluronidase infiltration with saline flush out technique. Next is diaper dermatitis. Diaper dermatitis is an acute inflammatory reaction of the skin in the perineal area. It is an extremely common pediatric condition. First, what happens is when the urine is accumulated, it alters the skin pH. It activates the fecal enzymes. The fecal enzymes causes skin destruction, microbes enters, and inflammation and secondary infection can occur. So what are the positive and negative recommendations for diaper dermatitis prevention and treatment? So this is from the evidence-based care of diaper dermatitis. The positive recommendations of zinc oxide, petrolatum, Ilex, which is zinc oxide and sodium polymer something, and antifungal products, frequent diaper changes, super absorbent diapers, application procedures for use of barrier products and antifungal products, diaper wipes. These are all positive recommendations, whereas negative recommendations are opening to air, antibacterial products and powders. Ilex contains calcium and or sodium copolymers, cornstarch and white petrolatum. Negative recommendations are open to air. We often counsel to open the air, which is not advisable, and powder is also not advisable. This is a perennial skincare guidelines for all diapered or incontinent patients from the Children's Hospital, Philadelphia. So how to, these are various scenarios. First, coming to first scenario, intact skin and no erythema. This is a normal situation where the child has not yet developed any erythema. The goal is to prevent skin breakdown. So Vaseline is recommended during every diaper change. For those with no erythema, normal baby, but there is a high risk of skin breakdown, like after post surgery, short gut, then you have to advise for triple paste or Ilex and Vaseline. Triple paste consists zinc oxide, petrolatum, and cornstarch. Triple paste has all the ingredients like Vaseline also, so just triple paste will be enough. Next, coming to situations where the erythema is already developed. First scenario is intact skin erythema, no evidence of candida. Second scenario is intact skin erythema with evidence of candida. So how to differentiate and how to treat? Intact skin with erythema, no evidence of candida, desitin, that is zinc oxide, is enough. And intact skin erythema and evidence of candida, antifungal, then desitin should be applied. And the next scenario is denuded skin, no evidence of candida and evidence of candida. In denuded skin with no evidence of candida, stomahensio powder and then triple paste should be applied. When there is evidence of candida, antifungal, then triple paste should be applied. These products, all these products, when applied, they promote moist wound healing. Therefore, do not leave the diaper open to air. Candida infection can be recognized with satellite lesion, usually involves the skin folds. So after these, coming to the general measures: skin to skin contact, cleansing, bathing, care of scalp, emollients, massage, care of cord, and use of talcum powder. Skin to skin contact. WHO strongly recommends skin to skin contact for all mothers and newborns without complication. Soon after the birth, the baby should be placed on the abdomen of the mother, and after the cord is cut, baby should be placed on the chest of the mother. Baby should be dressed only in diaper and left on mother's chest, and both of them should be covered with a warm blanket, at least for 1 hour. What are the advantages? It calms and relaxes both the mother and baby. It regulates baby's heart rate and breathing, stimulates digestion, regulates temperature, colonizes the baby's skin, and stimulates the hormones to support breastfeeding and mothering. Next is cleansing. Immediately after the birth, blood and meconium should be gently removed, not vigorously scrubbed, because vigorously scrubbing would remove vernix. Leaving vernix on the skin for at least 6 hours is recommended by WHO. For ELBWs, we can't, because we receive the ELBWs in plastic wraps and we are not supposed to remove the blood and meconium vigorously. They can be removed over multiple cares over the first 72 hours without disturbing the infant. And blot the skin with 100% cotton absorbable material and never rub the skin or wipe the skin of ELBWs. Bathing. The first bath should be given once the infant has achieved cardiorespiratory and thermal stability. Guidelines recommend that the first bath occurs between 6 to 24 hours. It is not less than 6 hours. So, but for infants born to HIV positive mother, the first bath should be given as soon as possible after birth in order to prevent transmission. For routine bathing for term infants, IAP and WHO suggest should be the infant should be bathed only every few days, and the duration should be limited to 5 to 10 minutes. Daily bathing is not recommended, and bathing can begin before the umbilical cord has fallen off. Frequency of bathing and time of bathing should be based on local culture. Evening bathing may help the infant and improve sleep. For preterm infants, less than 22 weeks of gestation, consider only using of warm water for at least first 1 week, because no cleanser should be used, because that irritates the skin, and because the stratum corneum is still formed, it disturbs the formation of stratum corneum. And in the preterm infants, if there is areas of skin breakdown, use only sterile warm water. And while selecting a cleanser bar or liquid cleansers, as we have studied about acid mantle, select liquid cleansers or cleansing bars that have neutral or mildly acidic pH, like 5.5 to 7. Ensure bath water ranges between 38 to 40 degrees and warm room temperature, that is 26 to 28. Close the door of the room to minimize air currents and convective heat loss. Also, there's a comparison between tub bathing versus traditional sponge bathing for the newborns. And there are many studies that have quoted that compared to the sponge bathing, tub bathing, infants experience significantly less variability in body temperature, and they are more warmer at 10 and 30 minutes after bathing. So, tub bathing is superior to sponge bathing. And in the tub bathing also, swaddle bathing is more effective than open tub bathing. Like we by like putting the infant open in the tub versus swaddling the infant and putting the infant in the tub and removing the swaddle and by bathing one part at a time. This is called swaddle bathing. Studies have shown that swaddle bathing is more effective in maintaining body temperature, oxygen saturation, and heart rate compared to open tub bathing, because infants may have uncontrolled motor activity when they are placed in a bathtub. This way, with swaddling, it reduces the infant and parental stress. Care of the scalp. First, hair wash should be given after the cord falls. Cradle cap of the scalp is a common problem. Application of mineral oil to the crest and removal after 2 to 3 hours will be helpful. Baby shampoos which are free of fragrance should be used. They should not cause any irritation to the eyes. Hair wash can be given once or twice a week. Coming to emollients, the three pillars of moisturizer are: one is humectant, one is emollient, and one is occlusive. Humectant is a product where when you apply it above the epidermis, it is a hydrophilic material. It absorbs water and it helps in it draws the water from the epidermis and the dermis, and it attracts water. Classical example is hyaluronic acid, where we use in extravasation injuries. Next is emollient. Emollient layer, when applied above the epidermis, it reduces the transepidermal water loss by filling in the gaps between the dead cells and replacing absent natural lipids. So a classical example is ceramides. As we have seen, Vernix caseosa contains ceramides. Next is occlusive barrier. The classical example is petrolatum. It forms a hydrophobic barrier over the stratum corneum and protects from barrier. It acts as a barrier. So this is a Cochrane database of systematic review of topical emollients for preventing infection in preterm infants. 8 trials are taken from in the systematic review. 8 trials are taken from developed countries where they have used creams and ointments. There was no effect on infection or mortality. 15 trials were from developing countries where they have used plant and vegetable oils. They have shown reduced invasive infection, and however, there's no effect on mortality. This is another systematic review where the topical application of coconut oil to the skin of the preterms was seen. Coconut oil significantly reduced lower incidence of hospital-acquired infection, decreased water loss, better growth, better skin condition, and has a better neurodevelopmental outcome. So summary of the emollients: as preterm stratum corneum is deficient, emollients have the potential to enhance barrier maturation, decrease risk of skin invasive infections. Of all the emollient studies, coconut oil has been shown superior to all the other emollients because it has high content of medium chain fatty acids. And sunflower, safflower, mineral oils can also be used. Olive oil and mustard oil should not be used because they disturb the skin barrier. Studies have shown that application of emollients in babies born to families with high risk of atopy tends to decrease the risk of atopic dermatitis. Coming to massage, oil massage has multiple benefits and is recommended. 15 to 30 minutes of uninterrupted time should be given for whole body massage. It should be done when the baby is quiet, alert, and active, preferably 1 to 2 hours after feed. Massage to be given in a warm room. It should be gentle and slow but firm enough to make the baby feel secure. Babies massaged with oil showed less stress behavior and lower cortisol levels than those who were not given massage without oil. Those who were given massage without oil. Care of the cord. Umbilical cord should be cleaned with lukewarm water and kept dry and clean. WHO recommends that nothing should be applied to the cord stump. If the cord has been soiled, it should be cleaned with water and mild soap and dried thoroughly with soft, clean cloth. Diaper should be clad below the stump. Talcum powders. Routine use of powders is not advocated. In case of infants, if the mother is desired to apply the talcum powders, smear the powder on the hands of the mother and then gently apply to the skin. Puffs should not be used as this may cause accidental inhalation of the powder. Powder should not be applied in groins, neck, arms, and leg folds. So take home message. Proposed guidelines for basic skincare is: in the delivery room, we have to provide immediate drying and tactile stimulation, remove blood and meconium, leave vernix intact. Limit bathing, delay bathing for first 6 hours, initiate the bathing or the temperature has been stabilized. Avoid cleansing agents for the first 2 weeks for the preterms. Use warm water and warm water. Surface cleansing is required not more than twice a week. Use adhesive sparingly. Place protective dressings at the site of frequent taping like ET tubes and NG tubes. And be aware of the composition and quantity of all the topically applied agents. So because preterms has more transepidermal water loss, select high humidity incubator and transparent semi-permeable resins to decrease the evaporative loss and water and heat loss. Apply a simple cream or emollient every 8 hours. Protect the sites of cutaneous injury with appropriate occlusive dressing. Use a fill-in dressing on non-exudative sites. Use a hydrogel dressing on exudative sites. Maintain appropriate hydration at skin dressing surface and remove necrotic debris with each dressing change. Thank you.
Well done, Nirusha.
Thank you.
So there are a few questions in the chat box. Can you go through it?
Rapid drop humidity, we come down 5% daily. Any recommendations on this?
You told no in the incubator,
Yes,
in the
ma'am,
first week, we have to maintain the humidity 80 to 85%. But normally, so after 1 week, the incubator humidity is brought down by 5% per day. But one of the study which you have quoted, they said that since maintaining humidity for long time can also delay the maturation of the skin. They found that by reducing the humidity from 80 to 50%, the skin maturity is better. But all these things require, even
after the
large.
first, yes, ma'am.
But whatever may be, we should see that after first week, you try to reduce the humidity in the incubator.
Yes, ma'am. Until the first 1 week, it is advisable to maintain till 85. After the first 1 week, you can come down by 5% daily. Next question is brand names of Stomahensive. Stomahensive powder is available in India. It costs around 500 rupees odd. How to give saline irrigation? So saline irrigation, stabs have to be when there is a severe extravasation injuries. Stabbing has to be made around 1 centimeter gap from each other, and saline has to be irrigated. If you are giving with hyaluronidase, 1 ml of hyaluronidase should be given for 1 ml of extravasate. And saline irrigation, there are various studies, but they have proposed 500 ml of saline should be irrigated, and we should see immediate flushing out of the saline from the stab injuries. Any institute following mother's vaginal swab for LSCS babies?
Not for all LSCS cases. Maybe few institutes, whenever there is a preterm PROM rupture of membranes, or spontaneous preterm, some institutes take vaginal swab regularly. In our institute also, we don't take for regularly for all cases, but for a few cases, we are taking the swabs. What is the next question?
Somebody has asked to show the skin barrier Cavilon photo once again, ma'am.
So somebody is asking about Cavilon also, Nirusha.
Yes, ma'am. Cavilon is a skin barrier, as I have shown here. It is a skin barrier products that is available now, where in places where you are you can't avoid putting a adhesive like Tegarum or some other adhesive which is not very skin friendly. In those places like at IV cannula site where you need strong adhesion, but you want to prevent adhesive injuries, this is one with which can you can use, like you can spray it on the skin before applying the adhesive. You can spray it and wait it for it to evaporate, and then you can put the dressing.
Yeah, recently, just last week only, we also came to know about this marketing. But personally, we have not started using in our unit. The marketing person has come and showed this product to us. Maybe we have to start using them and see for our babies.
Ma'am, that's all with the questions. That's all with the questions, ma'am. No further questions.
Any seniors want to give any comments?
Two more questions have come.
Dr. Alimelu, madam.
I think
Very good presentation, Nirusha. As we all know, this is so important to take care of as we nowadays we are seeing so many preterm babies being referred and managed in various units. We have to know all these things. Some other question has been come for
Removal of
removal of
adhesives.
adhesives.
There are also adhesive removal agents, which are of various types. Silicon-based adhesive removers are also being available. They can be, while removing the adhesive, those can be used. And before removing the adhesive, like at our place, we use cotton balls. We wet it in and we wet it adhesive and then we remove it. That is also approved, and adhesive removers are also available. Silicon-based adhesive removers are the best by far.
Maybe you can
Somebody has
put it
asked
in the
about Sensi. Yes, ma'am.
Hmm.
Somebody has asked about Sensi Care. We use Sensi. Sensi Care is also a type of adhesive releaser, I suppose. I mean, adhesive removers we did not cover in this PPT, but adhesive remover is also one new thing which is available.
Maybe you can put some pictures of them in the group after the
yes, I
presentation.
think so.
The
Okay, ma'am.
sensitive.
Okay, ma'am.
So very good presentation, Nirusha. I think day in, day out, we are always handling babies, and this is one neglected topic. And this shows the importance because we, as Dr. Swapna mentioned, and it's known that this is the largest organ in our babies. One more important point which I would like to mention here is sometimes when you have some skin injuries or some pustules on the skin in a term neonate, it's also better to send the swab for cultures. So we are seeing a lot of MRSAs as well, and it's very important then to use chlorhexidine wipes, isolating the baby, using the correct antibiotic for 7 days, and using muprosin for nostril application so that there are no comment, they don't retain, and they can always be a reactivation. So this is one more important thing that when you see some pustules on skin, please send the swab as well. And any more questions? Or anybody wants to add any comment?
Which is the best skin-friendly plasters, adhesive plasters, Nirusha?
Hello,
Which is the best
ma'am.
for skin? Like
Silicon
final
is
one word.
yeah, ma'am. See, silicon is the best testing as far, ma'am. But because of low adherence, we can't use it for life-saving devices. And the next best would be deodorant, ma'am.
Yes. So Diodum and Tegadum we are using. Recently, we even thought of using that. Merci, this one, but we couldn't get it freely.
Yes, ma'am. One more question. Any specific mineral oil? Mineral oil, I didn't see, but they say coconut oil has a best outcome, best among all the trials. There are multiple trials regarding coconut oil, and it has been shown to be very superior to other oils. No idea of any mineral oil. I mean,
Yeah, mineral oils also are good. But right now we have a lot of studies on coconut oil taking over mineral oils.
yes,
So
ma'am.
there were earlier there were some studies saying that both were almost equal. But I think now the latest things are adding up or supporting more in favor of coconut oil, like you mentioned, because of the medium chain.
Yes, ma'am.
And coconut oil is cheaper also.
Yes. And one more, these are all practical issues where many new parents do come to your offices and ask about which soaps to use, which lotions to use, and being aware of the acid mantle, suggesting the correct syndet, uh, and the correct emollients, how to manage the baby when before the cord drops off, how to bathe the baby before cord falls off, and after that. All these are day in day out problems or what you will be handling in future as well in your offices. So knowing all this is very important. And cradle cap, or the seborrheic dermatitis, atopic dermatitis, all these are common issues now. and how to solve them and how to handle these problems are something very important. So not just ventilated management, all the other issues, even these have to be known. So these are all day in and day out problems as well. Any more?
Mineral oil for cradle cap, ma'am. Someone has asked. Petroleum jelly and one more mineral oil can be used for cradle cap. Uh, not sure of the brand or this type of mineral oil which to be used.
No, the regular, the ones that are commercially available, most of the mineral oils are safe, except that they shouldn't be having any strong smell. And actually advising them to keep the scalp dry, not using the caps. And of course, applying too much of oil and keeping it constantly wet also increases the problem. So they should be told which shampoo to use for the scalp. All these are very important.
Next is best soap and lotion. Actually,
Mhm.
IAP recommends not to use any soap. If they're affordable, gentle cleansers have to be used because soap is harsh on newborn skin. So IAP doesn't recommend any soap. If they have to use soap, they're not affordable. Then any soap which is gentle and a pH in the range of mildly acidic to neutral pH that can be used.
Yes. Yeah, and then even if we are advising the soap, ask them to first lather it on their hand rather than putting the soap directly on the baby's skin. This is again a practical issue, day-to-day problem. Tell them not to put the soap directly onto the baby's skin. Instead, make some lather into their hand, and using that lather on the baby's body would be better.
Next to this, they've asked about lotion.
Any emollient.
Any emollient. So
Yeah,
those infused with ceramides are the best,
ceramides
especially
are
for
the best.
preterms. Yeah, especially
Yeah.
for preterms. Like it shouldn't be any marketing gimmick or anything, but truly infused with ceramide should be the best lotion or
Yes.
cream for preterms. And shampoo. They've asked about shampoo also. Something around the tears pH and that doesn't irritate the eye. Eye should be the best shampoo. I mean, not aware of any brand names.
No, there again the pH that is around 5.5. Say most of the newer, very expensive shampoos are available.
Yes, ma'am. And also
Yeah.
only water wash is not enough because water also has a pH of 7. It also disturbs acid mantle. So gentle cleanser should be used. Only for preterms for first 1 to 2 weeks, cleanser should be avoided.
Yes.
That's all.
If
Yeah.
there are no more questions,
Thanks, Nirusha, for bombarding the answers for all the questions.
yeah.
I
And
believe
very
this
good presentation, Nirusha. Very thorough, and you made it very lucid.
Thank you, ma'am.
Thank you. Thank you.
Thank you. Stop recording.